Hello, and thank you for being here. We appreciate your time. My name is Iradukunda. I am a nurse and an assistant professor at UMass Amherst. During this leadership journey, I was honored to be inducted into the American Academy of Nursing. I would like to start my presentation by expressing my gratitude to the women in my life who have shaped me, particularly Black women, whose leadership capabilities are often rendered invisible or hypervisible for critique. One of my areas of interest is power dynamics in global health leadership, and trying to address the question I've asked way too many times in global health spaces: where are the nurses? If you are a nurse in global health spaces or healthcare leadership spaces, you know exactly what I'm talking about. If you are not a nurse, I want you to start asking this question. Ask this question when you go to global health conferences. See how many nurses are there. Ask again when you go to a strategic meeting to set up an agenda that will most likely be implemented by nurses. You will soon realize what nurses know very well, especially minoritized nurses, that nurses are severely underrepresented in these spaces. But why are they? Especially when they make up more than half of the healthcare workforce, and especially when they are the primary implementer of global health programs. During this leadership journey, I decided to look at this issue. And while there are many angles that can be taken and many barriers preventing nurses, especially nurses from low and middle income countries, to be in healthcare leadership positions and global health leadership positions, I decided to focus on barriers that are internal to nursing, since this can be addressed within nursing. So let's talk about power asymmetry within global nursing. Within nursing, there are considerable power imbalances when it comes to who gets to lead the nursing agenda. Nurses from low and middle income countries have very little say. My project looked at factors leading to this and proposed some solutions. I will not be able to go over everything, but will give a brief overview of our manuscript, a manuscript that will hopefully soon be published. Some of the major factors are historical. We looked at coloniality and origins of power asymmetry in nursing leadership, policy, and decision-making. Particularly, we examined how the power dynamics established by the Colonial Nurses Association when interacting with local or native nurses are still in play today. We also looked at how this leads to the hegemony in nursing education, research, and practice. Question about who has the knowledge, who decides the content of nursing curricula, and qualification standards were addressed. We then looked at the lack of leadership pipelines and discussed issues of incivility, bullying, microaggression, lack of support, and racial bias, which are not only deterring young nurses from taking leadership positions, but also driving them away from this beloved profession. So what do? We love solutions here. It is important to redefine what we mean by representation. Let me just say that having one nurse is not enough. In fact, it can be damaging. Black scholars have explained the toll of being the only. So what would it mean to have enough representation of nurses in global health leadership and in healthcare leadership in general? We can answer this by doing some simple math. We also need to acknowledge and respect leadership capabilities that nurses have. Leadership trainings are good, but they don't replace being in actual leadership positions. In my experience, trainings often generate more trainings. Let us remember that nurses manage population's health, sometimes in the most gruesome conditions. Let's believe them when they tell us and show us that they know how to lead. We also need to remove barriers to entry and cede power. Have you ever been told that you need more than 20 years of experience to apply for a position that has historically excluded people from your discipline, people who look like you and speak like you? That's a real barrier. Other barriers are related to privileges. Nurses often need information, recommendations, sponsors, funds, among other things, to be able to apply for leadership positions. This means that nurses not connected to these resources won't stand a chance, not because they lack leadership capabilities, but because they lack privileges. Ceding power is also important. No matter how hard we try, power cannot and will not shift if it is not ceded. The self-awareness and willingness to engage in decolonizing nursing should involve ceding power. So what are some of the next steps? We want to have more listening sessions with nurses from low and middle income countries to understand and collect their recommendation. We also want to continue making recommendations to leading organizations interested in change. Finally, we also want to be able to examine and address external barriers. Those are barriers outside nursing. As I wrap up, I would like to express my gratitude to you all for listening, and to my family, mentors, sponsors, co-conspirators, and nurses who have and continue to inspire me. Finally, to nurses at the forefront of every global health catastrophe, I see you. You inspire me, and you deserve more than half of the seats at every table. Thank you.